Hello and good day to you. This is Tracy Harrison from the School of Applied Functional Medicine, and I want to invite all progressive healthcare practitioners to come and join me and your colleagues from around the world and so many modalities, where we're going to dive into how too much of a good thing can exacerbate disease. This is essential practitioner know-how and dives into some of that nuanced consideration in the realm of functional medicine application that we think it's essential practitioners have good capability and confidence in applying. I'm delighted that you're taking a chance to join us here at the School of Applied Functional Medicine. We feel very privileged, and it's certainly a pleasure to work with practitioners from around the world. Our current student body hails from 22 different medical and wellness modalities, actually at present from 76 countries around the world. And so you're very welcome here in your diversity. But I want to dive right in because I have an awful lot to talk about today. It can be really easy in any modality in an effort to find efficiency and focus in our practice to have sort of quick fix solutions or one-size-fits-all solutions that we recommend to our patients and clients. And while good guidance may apply to the lion's share of individuals we're supporting, there are always going to be devil in the detail instances in which that good long-standing guidance just doesn't make sense. And not only could it not be health promoting for an individual, it might actually be disease exacerbating. And I'm going to jump right in because one of the most obvious of these is the whole notion of exercise more, right? We know that the human body is designed to move. A sedentary lifestyle completely on its own promotes disease. We are not designed in order to be fixed or sedentary. It surprises a lot of your patients, I'm sure, to be educated and learn that being sedentary in and of itself is stressful to the human body. It goes counter to what a lot of people would assume about the benefits of laying around and vegging out. But on the other hand, often the patients and clients that we serve can take the notion of movement or exercise to an extreme. And indeed, there are always going to be circumstances in which more exercise is not better. And in particular, I want to draw your attention to individuals who seem very attached to extremely aggressive exercise. It can be easy for anyone to see that as being somehow valuable. More is better, right? It's a great balm to my super stressful lifestyle in order to get more exercise. But something that is happening behind the scenes that is often overlooked by practitioners is the notion that aggressive exercise, like long runs or spinning classes, right? Aggressive aerobic exercise. Sometimes individuals are actually self-medicating with this adrenaline promoting activity because behind the scenes, they may be producing suboptimal levels of stress hormones. And in particular, they may be struggling with more of a hypoadrenal state where they're not putting out sufficient levels of cortisol on an ongoing basis as our primary mainstay stress hormone. And this can actually drive people to subconsciously seek adrenaline promoting activities. And that's not just a matter of substances like sugar or caffeine, but also adrenaline promoting activities. And this can certainly include exercise. And so we want to be very cautious about thinking about a given individual. Very aggressive exercise also generates purposefully quite a bit of oxidative stress in the body, which if a person has fairly well supported endogenous antioxidant function, then a little bit of stimulatory oxidative stress actually acts with hormetic effects, right? The stimulation of the need for antioxidant support actually helps to fuel our ongoing antioxidant status. But if you have an individual who already is struggling under the burden of substantial oxidative stress and damage, in obvious situations, maybe on the other side of a rough battle with COVID, but maybe in less obvious situations, such as people who are struggling with type 2 diabetes and that hyperglycemia is creating a tremendous amount of oxidative wear and tear, or individuals who are struggling with quite a bit of toxicity, or who live in quite polluted types of circumstances, individuals who have genetic impairments in their endogenous antioxidant capability, such as for glutathione synthesis, then this is where we can actually see individuals really suffer greatly from doing even moderate, much less aggressive exercise until their antioxidant function is better supported. On the other side of a fairly aggressive aerobic activity, they don't recover well. They feel exhausted. They have heavy, fatigued limbs. And in this case, more exercise, while well intended for others, may be quite counterproductive for certain individuals. And so we want to be keeping this in mind for specific people. A hypoadrenal state also can promote excessive loss of sodium and water from the body, and this more sort of stimulated risk of dehydration can also increase the amount of recovery time that it takes individuals to bounce back from exercise. So a good example of where too much of a good thing can actually be counterproductive. I also want to say a word today about certain supplements, because this is a real pitfall with regard to functional medicine application in a clinical setting. Most practitioners through the lens of functional medicine have learned that there are specific supplemental nutrients or particular herbs or amino acids that can have beneficial application. And of course that is true, but we always have to consider who is this individual and what is ideal for them. It's why at SAFM we practice so much real life complex case practice, so that practitioners can go beyond just the basic knowledge or the scientific understanding of how a certain supplement works or how the nutrient might help, but actually take it to the point of wisdom, where there's true capability and confidence in considering whether a certain supplement should be used in a given case, and if so, how can it be most safely and effectively utilized. A great example of this is vitamin D, which remains a hip and hot supplement appropriately with regard to its importance for immune function, certainly emphasized quite a bit during the pandemic. But in our practices, we are, of course, continuing to support many individuals who are using high dose vitamin D, or you may have as a tool in your conventional practice the notion of, for example, weekly high dose vitamin D, like a 50,000 IU dose. And many individuals love and consider the concept of a single bolus dose on a weekly basis, or even worse, on a monthly basis, as being not only convenient, but innocuous. And how much difference could it make whether I take 50,000 once a week, or whether I take 5,000 or 7,000 once a day, or again, individuals are even taking 100,000 every 2 weeks. But it does make a difference, especially if you're introducing this large dose to individuals who already have a low vitamin D status. And this is, of course, the fact that vitamin D doesn't act alone. No nutrient in the human body acts alone. We need other cofactor nutrients in order to support the metabolism or utilization of a given nutrient. And of course, this is true for being able to convert vitamin D to its final forms. And this is the case whether we are acquiring vitamin D precursors from food, from sunshine, or from supplement. We need key nutrient cofactors, and one of these is magnesium. And many individuals who are recommended to begin using vitamin D, and this is especially of concern if it's in high dose, have a marginal or a truly deficient status of magnesium. And because that vitamin D supplement is going to have to use a significant amount of magnesium to support its metabolism, the use of the vitamin D could actually render someone magnesium deficient, and they could end up displaying and struggling with symptoms that they associate with the vitamin D, but they're actually being promoted by the excessive utilization of their already limited magnesium. And this is going to be, of course, much worse if we use a large bolus dose. Yes, vitamin D is a fat-soluble vitamin, but if we're taking it, for example, in a large single bolus oral dose, it's going to require a lot of sudden magnesium for purposes of converting that vitamin D for multiple stages, by the way, of vitamin D metabolism. And so we always want to be thinking about what are our interventions going to require in terms of cofactor or associated processes. And so it's good wisdom to think about supporting optimal magnesium status before beginning vitamin D. Supplementation. Of course, vitamin D also doesn't even act alone. Vitamin D and vitamin A are taken up together in some of the oldest receptors that the human body has, and high dose vitamin D can also put excessive pressure on already marginal status of vitamin A. And we may assume because a person is using precursors for vitamin A, like beta carotene, that their vitamin A status has got to be fine. Well, maybe not. Not everyone well converts precursors to the final retinoid, fully formed vitamin A. And if, for example, an individual is following a vegan diet, then they're going to be getting exclusively those precursor forms, which they may very well convert, or they may poorly convert to other forms. And so this is something we have to keep in mind when we are making supplement recommendations for a unique individual. Higher doses are not necessarily better. Bolus doses are not necessarily better. In fact, it's important, we teach, in order to ramp up vitamin D dosage, in order to give the body an opportunity to adjust actually to this fat-soluble vitamin being progressively increased in the body. But too much of a good thing is not necessarily better when it comes to lab work as well. There are so many markers that through a conventional or traditional lens we are taught or we learn to treat as either good things or bad things. And more of the good things is always better, and less of the bad things is always better. And we can end up using these types of shortcut assumptions in our interpretation of lab work, and that can also lead us awry. One of the best examples of more and more of the good stuff is not better has to do with HDL, right? High density lipoprotein. We often jump to the quick fix label of the good cholesterol, and many practitioners through the functional lens know that those relatively old labels are not appropriate, right? LDL is not a bad cholesterol. It's actually the lipoprotein carrier or vehicle for all cholesterol that leaves the liver to go out to the rest of the body to perform all sorts of different service, whether it is assisting our immune function or delivering cholesterol to various tissues to serve in tissue repair and new cell generation, right? Cholesterol is a key component of cell membranes for ensuring that we have sufficient stiffness and structure in our cells. We don't want to have too much, but we also don't want to have too little. There is a reason that the liver makes cholesterol in an effort to ensure that regardless of what we're consuming in our diet, that we have sufficient levels of it. But HDL is also not always the good cholesterol. In fact, our research has really made clear, just in the past, I would say 10 years or so, that excessive levels of HDL may be reflective of a high oxidative stress state. And this HDL can actually become quite dysfunctional and lose its reverse cholesterol transport capability and actually contribute to atherosclerotic potential. So for individuals whose HDL really starts to climb up there, I would say above 90, certainly above 95, don't assume, we should not assume that this is necessarily a good thing, a positive thing, something that is contributing to greater health and wellness. We want to investigate because especially in individuals who are maybe struggling with insufficient antioxidant function, that elevated HDL in their labs may not be a good sign. It may be a wake-up call for looking for other markers of excessive oxidative stress, such as too low levels of bilirubin, or maybe too low levels of uric acid, right? That's surprising to a lot of practitioners. There is so much devil in the detail in everyday annual physical lab work that ends up getting overlooked by many practitioners. And we can learn to see basic everyday labs with a keener eye, right? A finer sense of interpretation to make sure that we're not missing anything. Now, at the same time, more of the supposed good stuff is not better, but at the same time, less of the supposed bad stuff is also not necessarily better. I mentioned the notion of LDL, right? That the lower it is, the better. Well, research doesn't actually show that that is true either, despite a lot of common practice in conventional medicine and an awful lot of marketing from pharmaceutical companies that are making cholesterol suppressive medications such as statins. But research has been showing for quite some time that the lowest quartile results of LDL as we age, especially as we get up into our elder years, actually increases death from all causes. And again, as a good reminder that LDL is not some evil substance in the body. We need sufficient LDL in order to drive our physiology. And in particular, we want to make sure that we are reducing sources or addressing sources of inflammation that can create a pro-atherosclerotic environment, especially in our arteries, but also in other tissues, so that the LDL that we need in order to thrive is not turned into a disease-promoting substance. But even going beyond LDL, there's other markers to think of. One of the ones that is often overlooked in interpretation of conventional labs, even something as ho-hum as a complete metabolic panel or CMP. Liver enzymes, right, or liver function tests. We're looking at markers such as ALT and AST and GGT or even ALP, right? These various enzymes. It behooves us to always keep in mind, what is this marker actually measuring? What is it actually teaching us about? And in the case of ALT and AST, for example, they are a marker of tissue turnover. They are a marker of evidence that a tissue is choosing to renew itself. And you want tissue to be able to do this. And in that sense, we don't actually want those markers to be rock bottom, because it is highly unlikely that the tissue is not needing to turn itself over to some degree. In fact, just the basic oxidative damage of normal living, normal cellular respiration, and certainly normal life, especially here in the Western world, it does promote wear and tear on tissue, and we want that tissue to be able to renew itself or to repair itself. And this is perhaps most important in the liver. And so when you see, for example, ALT and AST well down into, say, the lowest quintile of the normal range, you want to be thinking, does that make sense in the context of this unique individual? Because like anything else, lab markers can only give us good objective assessments of what we are looking for it to measure if the body has sufficient supply of all the nutrients that are needed to make the thing we're measuring. So like anything else, these enzymes in the body require nutrients for synthesis, right? And in particular, these classic liver function test enzymes require vitamin B6 as a cofactor for their synthesis. And individuals who have inadequate states of vitamin B6 are going to struggle to make optimal levels of these enzymes. And in these particular cases, low levels of ALT and AST are first of all not a good sign at all. They are likely an indicator of a special stress and challenge in the liver that then the liver is not able to repair itself from. And so not only is the super low or even clinically low ALT level not typically something to celebrate, it's also a wake-up call that the marker is disconnected from the actual state of the body we're looking for it to measure. And because the tissue cannot repair itself, we are probably struggling more with actual function. And so this is a great example of something where we want to be thinking beyond just, quickly looking down the lab markers and looking for low and high flags. We want to be thinking, okay, wait a minute. Does this make sense in the context of this person? Is this a logical outcome for this particular individual? Another great example of this is blood sugar, right? We may want to see an individual with a low hemoglobin A1C, right? Or even a low fasting glucose, but a low hemoglobin A1C. We're looking to see that they're eating a low glycemic diet and they don't have challenges. They're far, far away from that pre-diabetic zone. But we need to stop and think when we see a hemoglobin A1C and we know what an individual is consuming in terms of their diet and think, do these go together? If a person is consuming a standard American diet with all of its refined sweeteners and refined grain-based foods, and maybe they have a sedentary lifestyle and a lot of stress, and their hemoglobin A1C is 4.9, absolutely we should always be thinking, okay, wait, that doesn't make sense. Those two things don't go together. This will allow us to do things such as measuring their fasting C-peptide or their fasting insulin, where we may learn that far from having optimal metabolic status, they may be in the second stage of metabolic dysfunction where they've actually moved to a hyperinsulinemic state. And the glycemic load of life is quite high, but what we're seeing is that the pancreas has already adapted to that and has begun to put out higher and higher levels of insulin in response to everyday lifestyle circumstances that are ultimately driving blood sugar down low. And of course, this can actually lead to hypoglycemic episodes. And we've spoken in prior sessions that the first stages of metabolic dysfunction do not present with elevated blood sugar. That actually comes way far down the progression of disease. What you're going to see as a first impact on blood sugar is low levels, hypoglycemic episodes, surprisingly low hemoglobin A1C. For that matter, another great example is you may see a surprisingly low fasting glucose, which is another reminder that that's not only affected by the body's baseline metabolic state coming off of an overnight of fasting, but you're also seeing a dramatic impact and reflection of a person's cortisol awakening response. And just because someone has a first morning fasting glucose that is seemingly optimal, say 86, right, 85, you cannot assume that that is a reflection of good around-the-clock metabolic health. Sometimes individuals have a fasting glucose of 85, but they have a hemoglobin A1C above 6. We see this type of thing all the time. Similarly, people can have a really high first morning fasting glucose. Maybe it's 110, but their hemoglobin A1C is 5.2%. These do make sense together if you know the nuances of the factors that are influencing specific markers, right? A person can have great general metabolic status, but they have a marked first morning spike in their cortisol awakening response, which usually just means the adrenal gland is adapting to an expected stressful state. It's part of how the body has survived. Humans have survived for so long is by predicting danger and the need to protect oneself given what's been happening in the recent past. But of course, it can be the other way around, where behind the scenes, there's quite significant metabolic dysfunction, but a person has lost their cortisol awakening response. They're trending toward more of a hypoadrenal state with a bit more of a flat line in their cortisol. And so their first morning fasting glucose is going to be inappropriately or misrepresentatively low. So again, we have to look beyond the surface in order to understand what is at play in a unique individual. Going even further in terms of looking at markers, homocysteine, we speak of this one often as well, right? We think about homocysteine kind of like cholesterol as being a bad thing. Well, that's not true at all. Certainly, we can increase our risk of cardiovascular disease by wrestling with too much homocysteine as evidence of suboptimal methylation status. But homocysteine in the body is actually a critical upstream precursor in the synthesis of glutathione. Yeah, we need homocysteine. And driving homocysteine way, way down to say, 1 or 2 is not a better thing. It's a great example of the necessity for balance in pretty much all substances that are normal endogenous things that the body synthesizes. And rock bottom homocysteine may actually be, especially if it's celebrated, may be belying suboptimal glutathione status because we're unable to synthesize sufficient levels, just like the liver enzymes. We have to have raw ingredients in order to be able to make these wonderful health promoting substances in the human body. And so this is devil in the detail that at SAFM we believe practitioners really need to know. And I'm just barely breaching the surface here of the dozens and dozens of key foundational concepts that practitioners really need to know in order to be able to capably and confident use their functional medicine knowledge in their practice in order to improve patient outcomes. Now, I also want to talk for a moment about some dietary choices, right? It's so easy to say, kind of like I started out with today, you want to be healthier? Change your diet, exercise more. Change your diet, exercise more, right? Good, generic, sort of useless guidance. If it was valuable, it would be transforming lives. But of course it's not, because people need tools. They need help. They need support. They need accountability. Just giving generic guidance is never enough to help someone change their lives if people aren't ready, willing, and able to actually make change. But it's also true that the things we think of that people just need more of all the time is not necessarily going to serve a given individual. And one of the things that I want to speak to in particular is a hot topic right now in the health media, simply because it's right after the new year. But it's been a hot topic for years now. But it doesn't change the fact that some people get all excited about the concept of green smoothies. And then they embark on a passion for green smoothies and they don't feel better. In fact, they feel worse. Green smoothie havoc is something that can follow on the other side of people not well tolerating what that green smoothie actually includes. And certainly people can put a whole bunch of different ingredients in a green smoothie, and we like to tell people vegetables. When in doubt, eat more vegetables, right? This is really what you need. But it depends on the person, and it depends on which vegetables that we are speaking of. And many green smoothies actually include quite a bit of oxalates. This is a real concern in terms of things such as spinach, beet greens, chard, and to some degree various cruciferous vegetables. We put a lot of foods that have a huge amount of oxalates into this smoothie, and then we whir it up into a liquid and we consume it, and of course we even more readily absorb those oxalates. Now, for a lot of people, this is not an issue at all. They have good diverse microbiome status, and they are able to well degrade oxalates in the gut, courtesy of various microbial species like oxalobacter and lactobacillus. We are able to degrade the oxalates, and also we are able to ensure we don't absorb too many of those oxalates by having good bile function. However, for individuals who struggle in the gut, patients who are post-cholecystectomy, or they have poor gallbladder emptying, poor bile function, or they may already be struggling systemically with various disease states that reflect oxalate overload, such as recurring kidney stones, or various pain syndromes such as irritable bladder or vulvodynia, pelvic pain for women. These are situations where you want to question whether or not oxalate overload might actually be at the root of their challenges, in which case a green smoothie is likely to be a pain-producing, but certainly a disease-exacerbating choice for them. And so again, we have to think about who is this particular individual. And so one size does not fit all. On the topic of vegetables, we could also talk about sulfur, right? We all love cruciferous vegetables, kale and cauliflower and broccoli and turnips, arugula, all of these foods loaded with sulfur. And we know that there are many benefits of these foods. They present with various phytonutrients like sulforaphane, things that help to stimulate different pathways like NRF2 in order to promote glutathione. And they're a wonderful food source of sulfur, which is an essential mineral within the body for many different functions. But not everybody well tolerates sulfur, especially from food, just like not everybody well tolerates a lot of oxalates. And so individuals can really struggle with sulfur overload in some cases. And so again, we have to consider, who is this person? Now, in terms of our body's ability to actually carry out optimal sulfur metabolism, because bioavailable sulfate is hugely important in human physiology, but a key cofactor mineral for sulfur metabolism is molybdenum. One that we love to say, molybdenum. Hard to spell. But molybdenum is a trace mineral that certainly individuals who are not used to consuming a healthy diet are quite likely to be deficient in. And individuals can also have common genetic variants, or SNPs, that put additional challenges on their sulfur metabolism. If they are not getting enough molybdenum, then they may struggle, especially in terms of having a lot of gastrointestinal distress or other feelings, especially of fatigue or headache, on the other side of ingesting a lot of sulfur. But a multi-mineral that includes a good amount, a balanced complement of molybdenum can be quite helpful. Occasionally people may need to actually take a separate molybdenum supplement, but again, not too much, because just as we've spoken of about other nutrients like zinc, minerals compete for absorption, and going off the deep end and overloading too much of any one mineral may cause a deficiency in another one, simply because of competition for absorption at the gut level, and also in many cases also absorption at the cellular level. So yes, molybdenum is what we're talking about. And it is not always included in a multi-mineral or a multivitamin. So if an individual is using one of those to try and fill in some key gaps while you're working with them on improving their diet, this is something important to consider. Molybdenum may be helpful, and certainly if it's what is missing, then they can supplement right along with the meals that have significant sulfur-containing food, and it should bring them marked relief. But there's another opportunity to think about that can be a real win-win in terms of an item for your toolbox, and this is the notion of an Epsom salt bath. Epsom salts are magnesium sulfate, and especially for individuals who may be already struggling with hypermotility, they may have fast transit time or diarrhea, we want to be very cautious about using any type of oral magnesium supplementation, except for maybe magnesium chloride, which tastes terrible, by the way. Not everyone can tolerate it. It's usually sold as a liquid. But it can be a struggle for individuals who have a deficient systemic status of magnesium, but they're already struggling with loose stools or diarrhea, and you can feel trapped where you want to boost magnesium, but you're not sure how to do that, and not everyone has access to IVs. And so an Epsom salt bath, a good, inexpensive, old-fashioned lifestyle healing choice, can be a great one to recommend to these individuals, because they can take up magnesium through the skin. This can be extremely relaxing to individuals, as well as a wonderful later afternoon or evening ritual in order to infuse the body with extra magnesium to help promote higher levels of GABA as an inhibitory neurotransmitter to just calm down the chaos in the brain in order to help people to relax and fall asleep. An Epsom salt bath can be a wonderful part of a customized sleep hygiene interventional plan. But it's magnesium sulfate. And this can be a wonderful way to introduce bioavailable sulfate into the human body, bypassing the GI tract. Now, one of the reasons that individuals can struggle with getting their sulfur from their diet is because they don't metabolize sulfur well. And another reason is because they already have an overgrowth of hydrogen sulfide producing microbes in their gut. And this definitely can be challenging. And so an individual really gets an exacerbation of their IBS-like symptoms when they're consuming these otherwise very healthy foods. And there's an interesting perspective developed in the naturopathic community several years ago that perhaps one of the reasons why the body allows, why the immune system allows a certain amount of overgrowth of hydrogen sulfide producing species is in order to trap sulfur in the body, because there is an inadequacy of bioavailable sulfate. Now, we don't have any actual evidence of that. In fact, I'm not even sure overtly how you'd be able to assess that in a meaningful way outside of a clinical study. But it's an interesting theory for sure. And we certainly have seen some individuals who begin the habit of an Epsom salt bath and they begin to get some relief in their hydrogen sulfide mediated SIBO. So an interesting opportunity to think about with regard to the interconnectedness, but a great way to make sure people are getting additional sulfur while they may not be tolerating it well in food is with an Epsom salt bath. That can obviously be a win-win-win for multiple reasons. Another food category that I want to talk about involves things such as bone broth and avocado and freshly squeezed lemon juice and kombucha. All of those sound really great, right? There may be things that we all, as a community of health-seeking individuals, we may enjoy these and include them in our diet on a regular basis. What are these foods going to include? Potentially a lot of that not everyone is going to well tolerate. Histamine overload. This histamine intolerance, I think, is something we all need to be looking out for, because this particular disease dynamic we are seeing clinically is even more prevalent than it was before, and unfortunately still overlooked like it was before, in association with the pandemic. And histamine overload simply means that the exposure to histamine, and this can be from exogenous sources, foods and beverages that actually overtly include histamine, like cultured foods such as kombucha, or it can be what is histamine producing or histamine liberating, we often call it, internal to the human body, right? And we think about things like a lemon juice. But it can also be histamine generated intracellularly by our own immune system, right? Any or all of these things contribute to histamine load. And then we're going to struggle with that being excessive, depending on to what degree we can degrade that histamine. Again, coming back to the notion of balance. Sometimes people have imbalances because the load is too high. Sometimes people have imbalances because the degradation is insufficient. Sometimes people have both. We have to think about both in this unique individual. And if we want to degrade histamine in the gut, we need to produce sufficient levels of diamine oxidase, which degrades histamine. It's a brush border enzyme created in the intestines. It needs vitamin B6 and other cofactor nutrients. But if a person has a chronic dysbiosis state, such as an ongoing intestinal overgrowth of hydrogen sulfide producing species, like I mentioned earlier, or maybe a chronic or recurring opportunistic overgrowth of candida, such as when individuals take regular courses of antibiotics, all of these things can create oxidative wear and tear in the lining of the intestines, which when it's chronic or severe enough episodically can absolutely damage our ability to create these brush border enzymes. And the brush border, this is where we produce enzymes that not only degrade histamine, but degrade dairy foods, degrade gluten, right? Is it any surprise that, for example, those are the foods that are often culprits in terms of things that our immune system becomes hyperreactive to in the intestines? Perhaps often in part because we're not breaking it down very well. It's a great example of interconnectedness. But systemic, intracellular, we use diamine oxidase, by the way, in various mucosa in the body, not just in the intestines. So for example, it's also important like in the bladder and in the urinary tract or in the vagina. But methylation is what we need to be able to do consistently and sufficiently to degrade intracellular histamine, right? The HNMT enzyme needs methylation in order to work. And people who have impaired methylation, whether it's genetically impaired or competitively impaired or nutritionally impaired, maybe all of those, we may struggle to degrade even moderate or even low levels of histamine that we're exposed to. And so if individuals are struggling with, the last thing they need is for us to recommend a lot of high histamine containing foods that for another person may be very health promoting, may be an awesome source, for example, of probiotics, or even in the plant food, right? The fruits and vegetables area may be an awesome source of phytonutrients. But again, causing us to question who is this individual, right? And how do we need to customize our suggestions? This is why at SAFM, a huge component of our training program is real life complex case practice. It's one of the things that makes us very different in the world of functional medicine education and training. Functional medicine, rigorous current science, right? Evidence-based science is so essential, and it is the foundation of our training. But knowing the science is not enough. It's not even close to enough. It tends to lead to practitioners that have a lot of knowledge, but they don't have a lot of capability and confidence. And so at SAFM, we think it's essential for practitioners to go through dozens, not one or two, not oversimplified, fake, or theoretical cases, but dozens of real life complex cases where you can actually develop some wisdom. You can learn from your peers about good street wisdom and tools for how do you respond to this disease dynamic in this crazy case. Well, what about that crazy case? Well, what about these weird circumstances? If you want to be capable and confident and on fire with enthusiasm and ease in terms of doing this work, then you have to practice. And you don't want to practice on your own patients and have that lack of confidence, that, dare I call it, even kind of imposter syndrome, where you have a credential, but you're not really sure you know what you're doing. None of us want to feel that way. It's a terrible feeling, but none of us wants to send our spouse or our child or our mother to a practitioner who deep down inside feels that. We take a stand for a higher truth and a higher standard of training. It's so essential to get case practice. I have two more things that I want to speak of that I think are essential, are really important. One of them is anemia. Now, we're all familiar with anemia, and most of you are likely well familiar that there are many types of anemia. We know to look for microcytic or macrocytic dynamics. A nuance, by the way, that a lot of practitioners don't look for is where a vitamin B6 or a copper insufficiency might actually be contributing to inadequate levels of hemoglobin. It's not always about iron. Sometimes iron is just not being mobilized, or again, we're not supporting sufficient enzymes that are needed to catalyze the synthesis of these key substances like enzymes. But it is so important that we don't assume someone has inadequate iron just because their hemoglobin is suboptimal, right? Or we assume they need more iron because their serum iron is suboptimal. We need to be checking an iron panel, and in particular, we need to be checking ferritin. We know that many of us have heard of the notion of anemia of chronic disease or anemia of acute disease. But what we certainly learned over the past nearly 12 years now that we've been educating practitioners is that this is way more common of a dynamic than you might think. where an individual's hemoglobin and serum iron are suboptimal, but their ferritin is clinically high or really quite robust. And what we're seeing is either an inability to mobilize that iron and then to use it in the proper catalyzed synthesis of hemoglobin, or the body is purposefully sequestering the iron away from an inflammatory dynamic. That could be from a very stressful dynamic, an infectious dynamic, a toxic dynamic. And so we must be sure to think about, again, who is this individual? I cannot tell you the number of people we've supported in various practices who have come into the practice taking iron supplements, and even before they began them, their ferritin was already high. And so we're not helping at all. We're actually exacerbating the disease state by pushing high-dose iron supplements on a particular individual. Now, for sure, some people need iron, but one size does not fit all, and we cannot assume that, oh, these markers are low, so more iron is better. No, not necessarily. We need to remember, in fact, that iron is perhaps the original heavy metal. We tend to focus on, oh, lead is a bad thing, arsenic is a bad thing, mercury is a bad thing. Well, too much iron is a really bad thing and can contribute a tremendous amount of oxidative stress and damage, especially if there are excessive levels of free iron. And so we really want to be cautious about this and make sure that we really check the status of some of these cofactor nutrients and really check for iron stores before we jump to the conclusion that people need more iron. Even the body in its own wisdom in the gut with digestion and absorption of iron, even in a healthy gut, we absorb it most, even optimally, I would say, maybe 15% of the iron that we consume, often less, 10%. It makes sense that the body well controls and also has regulatory proteins that influence to what degree we are allowed to take up iron from the gut. And because of the regulatory effects of hepcidin, it actually is much better. It tends to be much better to take iron supplements every other day rather than every day, and certainly not multiple times a day, because we're simply going to fire up the body's hesitation and maybe defensiveness around wanting to restrict iron absorption, and elevated levels of hepcidin will prevent that iron absorption even if we're consuming a massive amount of it, whether it be from food or diet. So again, devil in the detail wisdom that you need as part of your clinical toolbox. The last thing I want to cover is on the topic of magnesium. Now, this is one that many of you may know, but misinformation abounds about magnesium. It is unfortunately becoming less and less prevalent in our food supply via high volume industrialized farming. And if minerals are not in the soil, they're not going to be in the food. Even beyond that, individuals tend to be, of course, eating a lot of highly refined foods where a lot of the minerals will have been processed out of the particular food product. But it's also key for us to acknowledge that another major driver for suboptimal magnesium status is that stressful circumstances promote increased loss of magnesium in the urine. It is a fact. And so this is where stress and our modern day most common root causes of disease, crap food, toxins, and stress, really are at the root, at the base of so much of what our patients are struggling with. And so many people need magnesium. We need to be checking magnesium status. Unfortunately, we can't pursue some of the best methods used in published research because they're not widely available in terms of assays. But red blood cell magnesium is a great way to check for cellular levels of magnesium. And by using a cellular level, we look at something that is more stable over many days of intake. And therefore, we're not going to see a serum magnesium level inappropriately optimal because someone happened to eat just in the past day or two a significant amount of magnesium in their food, right? They ate a bag of almonds abnormally when their normal diet is deficient, right? This is part of the downside of serum levels of nutrients. They're only a reflection of what people have done over the past few days. So we need to be checking cellular levels of magnesium. But once again, there's wisdom in the forms of magnesium that we need. We have on our SAFM website, you can go actually to the clinical tips page on our SAFM site and search for the word magnesium. And it will bring up an awesome post that shares with you many different types of magnesium and when to consider each for specific circumstances. There are multiple forms of magnesium that are highly likely to promote diarrhea all by themselves. You take someone who has type 2 diabetes, who is statistically more likely to be deficient in magnesium because of the disease dynamic, but they're also, at least in the US, likely to be taking metformin. And in many individuals, metformin increases transit time and can actually promote diarrhea as well. You end up with further loss of magnesium due to malabsorption because of the diarrhea. And then an individual ends up taking what? Magnesium citrate, magnesium oxide. Many of the cheap, readily available forms of magnesium are going to worsen that. And a major outcome of diarrhea is gross multifactorial mineral deficiency. Because if we have fast transit time, then we're going to struggle typically with dehydration, suboptimal essential fatty acid and fat-soluble vitamin status, and suboptimal mineral status, because these are notably influenced by a rapid transit time. There's not enough time for optimal nutrient absorption in the duodenum and in the jejunum, in the small intestines. For that matter, people can actually have magnesium-mediated magnesium deficiency, where the form of magnesium they're taking is creating diarrhea and even keeping them from absorbing magnesium from their food. An interesting catch-22 that can really get in the way. So know your forms of magnesium, know what is most appropriate. Some forms are particularly good for anxiety. Some are particularly good for arrhythmia or cardiovascular concerns. Some are better for systemic needs. Some are helpful for constipation, but then you want to use a form that's well absorbed systemically as well as supporting the gut. We actually have hundreds of clinical tips posted on our public website that are available to any and all practitioners at any time. There are also dozens and dozens of videos like this one on specific topics that you can search for in order to learn more about a certain disease dynamic. We have posts about applying functional medicine in conventional practice. We have posts about working in multimodality partnerships. We have posts about how to do an awesome intake. Wow, that sounds like such a boring topic, but it's something that the majority of practitioners could really benefit from picking up more tips about how to do it thoroughly and effectively. We have videos on how to facilitate lifestyle change, because knowing the science is not enough. You can have the perfect interventional plan, but if you can't help to educate, inspire, and empower someone to change their life, then to be accurate, your knowledge isn't worth very much. In terms of having an impact on healthcare transformation, we have to be able to go from the science, not just to the plan, not just to the clinical encounter, but to the clinical impact. That's our mission. That's what most of us are craving, right? That's our passion, our calling, our drive to really have that impact, one curious and open patient at a time. But I want to thank you all so much for joining me today and setting aside time to increase your knowledge, to increase your know-how, and to increase your clinical toolbox. It's a real privilege for me and our team at SAFM to be in service to all of you and your passion, your calling for not just being excited about healthcare transformation, but to being an active participant in it, right? Being a leader in it. Because healthcare must be transformed. In our lives, we will see truly effective, affordable, accessible care that gets at the true roots of disease. And we, with you, want to make that happen.